Hello, I'm Dr. Bob Frykberg, and I'm happy to be with you here today to give my very brief overview of diagnosis and treatment of diabetic foot wounds. It's a pleasure to be with you. At some point, I'd like to be with you in person. Now, many years ago, I became acquainted with this paper, Menace of Diabetic Gangrene, published by Elliot Jocelyn in 1934, and he said, "Diabetic gangrene has been increasing as a menace to my patients." And I'm sure we can all agree that diabetes and gangrene are still menacing our patients. Now, the diabetic foot is very complicated, or can be a very complicated and complex problem, but we recognize that neuropathy is one of the key components, as well as vascular disease. And neuropathy we recognize is not just a sensory, but also motor and autonomic neuropathy. And vascular disease is not just macrovascular disease, but also microvascular disease and the underlying microneurovascular disturbances leading to that high-risk foot. When we apply trauma to that high-risk foot, either by walking barefoot or wearing a tight shoe or what have you, with the person's impaired response to infection, they get a break in the skin envelope, leading to a diabetic foot ulcer. This can go on to develop infection and gangrene. And once gangrene develops, we need to do amputation at some level. And it's our job to amputate at the most distal level as possible, if not preventing that amputation in and of itself. Now, this is an old paper, but I think it simplifies a very complex problem. Recognizing that Gail Reiber published this in 1999, and she looked at a number of different causal pathways leading to diabetic foot ulcer. And she found this critical triad in 63% of the pathways leading to foot ulcer. And those component causes included neuropathy, deformity, and trauma. And we can recognize how these are very important component causes leading to ulceration. And the deformity and the trauma really can represent high foot pressures from various foot deformities. So with that, it's an idea both for treatment as well as prevention. This paper was published in the Journal of Vascular Surgery in 2010, and it's a simplified way to look at the causal pathway leading to amputation. Here we have that high-risk foot at the bottom stair, if you will, leading to injury based on some type of a problem, even an untreated callus or third-degree burns, second-degree burns, as we see here in Phoenix, Arizona. Then we have a chronic wound. The wound becomes infected when it's not properly treated. It can develop gangrene, and when gangrene develops, at some point, it's going to require amputation. And this is where we can see there are multiple opportunities for amputation prevention here. So we have to recognize that there are many evidence-based guidelines in publication right now. And you can pick and choose your guideline. Most of us are looking at the International Working Group guideline published in 2019 update, but pick any one that's convenient. Diabetes Care publishes a new standard of care every year, but we need to follow these guidelines carefully. They really haven't changed much in the last 15, 20 years, except technologies have changed, but we need to follow the basics of care. And the treatment of the ulcerated foot in 2022 is no different than it was in 2002, except for some new types of advanced therapies. But the treatment always rely on the basic tenets of care: remove or correct the etiologic cause, concurrent medical management, vascular diagnosis and revascularization as appropriate to restore a pulse, and looking for infection, doing the appropriate incision and drainage with culture, antibiotic therapy, as well as surgical drainage. Wound care consists of debridement, offloading, dressings, advanced therapies, whichever you have available, and foot surgery has become a very important part of our overall treatment to the ulcerated foot in this decade. And then we cannot forget about the importance of prevention after healing. And that requires use of therapeutic footwear, constant surveillance, and again, prophylactic surgery as necessary. Again, these basic treatment tenets are very well documented in any one of the clinical practice guidelines currently in publication. Now, this is a very simple algorithm for my approach to diabetic foot ulcers. And I like to make a complex subject matter simple if I can. Here we have that diabetic foot ulcer upon its presentation. We know we need to do a clinical examination, a thorough systematic examination, looking for deformity, assessing vascular status, looking for infection by probing those wounds, seeing if it probes the bone or down tendon sheaths. And of course, then we'll get an x-ray, looking for any foreign bodies or bony erosions or deformities. Then, of course, our basic care involves debridement of the ulceration and proper offloading, whether it be a total contact cast or a removable cast walker or even a wheelchair. But offloading is absolutely essential, and that's where many people fall short. Footwear, shoes alone are not good enough. We need to offload properly with a cast or with a removable cast walker. Then we revascularize as necessary, predicated upon our thorough examination. We liberally perform diabetic foot surgery to correct deformities, to raise flaps, to cover chronic wounds, to remove underlying bony prominences or osteomyelitis or incision and drainage of infection, etc. And then we'll also use advanced therapies, whether it be a skin graft, a skin substitute, negative pressure therapy, hyperbaric oxygen, topical oxygen, whatever you might have. And then once healed, we need to always provide for protective footwear, because we recognize from all the previous discussions that the patient who has healed a ulcer or an amputation is at the highest risk level 3, for developing another ulcer. So we always must provide for proper protective footwear and lifelong surveillance to intervene early should problems arise. And once again, as has been stipulated since 1934, multidisciplinary diabetic foot surgery, or a multidisciplinary team, is critical. Here is just my model that I've used for several decades, where the podiatrist is the gatekeeper, because we tend to follow our patients most carefully, but we accept referrals from primary care physicians or hospitals. We work with our vascular surgeons, our internists, diabetologists, and all of our consultants and ancillary services, along with that foot in the middle, which represents the patient. Without that patient's adherence and engagement in our care, we're never going to be successful. So we must all practice in some type of a multidisciplinary environment if we're going to provide the best of care to these patients. And so, as Jocelyn had said in his paper, consequently, it has been forced upon me that gangrene is not heaven sent, but is earth-born, meaning there are many causes for gangrene and infection, and it is our job to understand those reasons and to intervene early and aggressively to prevent the progression to gangrene and subsequent amputation. Then we will have done our job. And with that, I want to thank you very much. It's a pleasure again to be with you, and I hope to be with you in person sometime in the future. So thank you once again.